Flutamide, sold under the brand name Ulixin among others, is a nonsteroidal antiandrogen (NSAA) which is used primarily to treat prostate cancer. It is also used in the treatment of androgen-dependent conditions like acne, excessive hair growth, and high androgen levels in women. It is taken by mouth, usually 3 times per day. Side effects in men include breast tenderness and enlargement, feminization, sexual dysfunction, and hot flashes. Conversely, the medication has fewer side effects and is better tolerated in women. Diarrhea and elevated liver enzymes can occur in both sexes. Rarely, flutamide can cause liver damage, lung disease, sensitivity to light, elevated methemoglobin, elevated sulfhemoglobin, and deficient neutrophils. Numerous cases of liver failure and death have been reported, which has limited the use of flutamide. Flutamide acts as a selective antagonist of the androgen receptor, R, competing with androgens like testosterone and dihydrotestosterone, DHT, for binding to ARs in tissues like the prostate gland. By doing so, it prevents their effects and stops them from stimulating prostate cancer cells to grow. Flutamide is a prodrug to a more active form. Flutamide and its active form stay in the body for a relatively short time, which makes it necessary to take flutamide multiple times per day. Flutamide was discovered in 1967 and was first introduced for medical use in 1983. It became available in the United States in 1989. The medication has largely been replaced by newer and improved NSAAs, namely bicalutamide and enzalutamide, due to their better efficacy, tolerability, safety, and dosing frequency, once per day, and is now relatively little used. Medical uses. Prostate cancer. GnRH is released by the hypothalamus in a pulsatile fashion. This causes the anterior pituitary gland to release luteinizing hormone (LH) and follicle-stimulating hormone (FSH). LH stimulates the testes to produce testosterone, which is metabolized to DHT by the enzyme 5-alpha reductase. DHT, and to a significantly smaller extent, testosterone, stimulate prostate cancer cells to grow. Therefore, blocking these androgens can provide powerful treatment for prostate cancer, especially metastatic disease. Normally administered are GnRH analogs, such as leuprorelin or cetrorelix. Although GnRH agonists stimulate the same receptors that GnRH does, since they are present continuously and not in a pulsatile manner, they serve to inhibit the pituitary gland and therefore block the whole chain. However, they initially cause a surge in activity. This is not solely a theoretical risk but may cause the cancer to flare. Flutamide was initially used at the beginning of GnRH agonist therapy to block this surge, and it and other NSAAs continue in this use. In contrast to GnRH agonists, GnRH antagonists don't cause an initial androgen surge, and are gradually replacing GnRH agonists in clinical use. There have been studies to investigate the benefit of adding an antiandrogen to surgical orchiectomy or its continued use with a GnRH analog, combined androgen blockade (CAB). Adding antiandrogens to orchiectomy showed no benefit, while a small benefit was shown with adding antiandrogens to GnRH analogs. Unfortunately, therapies which lower testosterone levels, such as orchiectomy or GnRH analog administration, also have significant side effects. Compared to these therapies, treatment with antiandrogens exhibits fewer hot flashes, less of an effect on libido, less muscle wasting, fewer personality changes, and less bone loss. However, antiandrogen therapy alone is less effective than surgery. Nevertheless, given the advanced age of many with prostate cancer, as well as other features, many men may choose antiandrogen therapy alone for a better quality of life. Flutamide has been found to be similarly effective in the treatment of prostate cancer to bicalutamide, although indications of inferior efficacy, including greater compensatory increases in testosterone levels and greater reductions in PSA levels with bicalutamide, were observed. The medication, at a dosage of 750 mg per day 250 mg 3 times daily, has also been found to be equivalent in effectiveness to 250 mg per day oral sapropterin acetate as a monotherapy in the treatment of prostate cancer in a large-scale clinical trial of 310 patients, though its side effect and toxicity profiles including gynecomastia, diarrhea, nausea, loss of appetite, and liver disturbances were regarded as considerably worse than those of sapropterin sapropterin acetate. A dosage of 750 mg per day flutamide, 250 mg, 3 times a day, is roughly equivalent in terms of effectiveness to 50 mg per day bicalutamide when used as the antiandrogen component in combined androgen blockade in the treatment of advanced prostate cancer. Skin and hair conditions. Flutamide has been researched and used extensively in the treatment of androgen-dependent skin and hair conditions in women including acne, seborrhea, hirsutism, and scalp hair loss, as well as in hyperandrogenism e.g., in polycystic ovary syndrome or congenital adrenal hyperplasia, and is effective in improving the symptoms of these conditions. The dosages used are lower than those used in the treatment of prostate cancer. Although flutamide continues to be used for these indications, its use in recent years has been limited due to the risk of potentially fatal hepatotoxicity, and it is no longer recommended as a first- or second-line therapy. The related NSAA bicalutamide has also been found to be effective in the treatment of hirsutism in women and appears to have comparable effectiveness to that of flutamide, but has a far lower and only small risk of hepatotoxicity in comparison. Acne and seborrhea. Flutamide has been found to be effective in the treatment of acne and seborrhea in women in a number of studies. In a long-term study of 230 women with acne, 211 of whom also had seborrhea, very low-dose flutamide alone or in combination with an oral contraceptive caused a marked decrease in acne and seborrhea after 6 months of treatment, with maximal effect by 1 year of treatment and benefits maintained in the years thereafter. In the study, 97% of the women reported satisfaction with the control of their acne with flutamide. In another study, flutamide decreased acne and seborrhea scores by 80% in only 3 months. In contrast, spironolactone decreased symptoms by only 40% in the same time period, suggesting superior effectiveness for flutamide for these indications. Flutamide has, in general, been found to reduce symptoms of acne by as much as 90%, with several studies showing complete clearance. Excessive hair growth. Flutamide has been found to be effective in the treatment of hirsutism, excessive body, facial growth, in numerous studies. It possesses moderate effectiveness for this indication, and the overall quality of the evidence is considered to be moderate. The medication shows equivalent or superior effectiveness to other antiandrogens including spironolactone, sapropterin acetate, and finasteride in the treatment of hirsutism, although its relatively high risk of hepatotoxicity makes it unfavorable compared to these other options. A study found that multiple dosages of flutamide significantly reduced hirsutism in women with polycystic ovary syndrome and that there were no significant differences in the effectiveness for dosages of 125 mg per day, 250 mg per day, and 375 mg per day. This supports the use of flutamide at lower doses for hirsutism without loss of effectiveness, which may help to lower the risk of hepatotoxicity. However, the risk has been found to remain even at very low doses. Scalp hair loss. Flutamide has been found to be effective in the treatment of female pattern hair loss in a number of studies. In one study of 101 pre- and postmenopausal women, flutamide alone or in combination with an oral contraceptive produced a marked decrease in hair loss scores after 1 year of treatment, with maximum effect after 2 years of treatment and benefits maintained for another 2 years. In a small study of flutamide with an oral contraceptive, the medication caused an increase in cosmetically acceptance hair density in 6 of 7 women with diffuse scalp hair loss. In a comparative study, flutamide significantly improved scalp hair growth 21% reduction in Ludwig scores in hyperandrogenic women after 1 year of treatment whereas sapropterin acetate and finasteride failed to do so. Transgender hormone therapy. Flutamide has been used as a component of feminizing hormone therapy for transgender women. At least 2 centers have been reported to use flutamide as an antiandrogen in transgender women. However, the use of flutamide for such purposes, as well as in cisgender women with androgen-dependent dermatological conditions, is discouraged due to reports of hepatotoxicity in men with prostate cancer at comparable doses. Available forms. Flutamide is available in the form of 125 mg oral capsules and 250 mg oral tablets. Side effects. The side effects of flutamide are sex-dependent. In men, a variety of side effects related to androgen deprivation may occur, the most common being gynecomastia and breast tenderness. Others include hot flashes, decreased muscle mass, decreased bone mass and an associated increased risk of fractures, depression, and sexual dysfunction including reduced libido and erectile dysfunction. In women, flutamide is, generally, relatively well tolerated, and does not interfere with ovulation. The only common side effect reported with flutamide in women is dry skin, 75%, which is attributable to diminished androgen-mediated sebum production. General side effects that may occur in either sex include dizziness, anorexia, gastrointestinal side effects such as nausea, vomiting, and diarrhea, a greenish-bluish discoloration of the urine, and hepatic changes. Because flutamide is a pure antiandrogen, unlike steroidal antiandrogens like cyproterone acetate and megestrol acetate, which additionally possess progestogenic activity, it does not appear to have a risk of cardiovascular side effects, e.g., thromboembolism, or fluid retention. Gynecomastia. Flutamide, as a monotherapy, causes gynecomastia in 30 to 79% of men, and also produces breast tenderness. However, more than 90% of cases of gynecomastia with NSAAs including flutamide are mild to moderate. Tamoxifen, a selective estrogen receptor modulator, SERM, with predominantly antiestrogenic actions, can counteract flutamide-induced gynecomastia and breast pain in men. Diarrhea. Diarrhea is more common and sometimes more severe with flutamide than with other NSAAs. In a comparative trial of combined androgen blockade for prostate cancer, the rate of diarrhea was 26% for flutamide and 12% for bicalutamide. Moreover, 6% of flutamide-treated patients discontinued the medication due to diarrhea, whereas only 0.5% of bicalutamide-treated patients did so. In the case of antiandrogen monotherapy for prostate cancer, the rates of diarrhea are 5 to 20% for flutamide, 2 to 5% for bicalutamide, and 2 to 4% for nilutamide. In contrast to diarrhea, the rates of nausea and vomiting are similar among the three medications. Rare reactions. Liver toxicity. Although rare, flutamide has been associated with severe hepatotoxicity and death. By 1996, 46 cases of severe cholestatic hepatitis had been reported, with 20 fatalities. There have been continued case reports since, including liver transplants and death. Based on the number of prescriptions written and the number of cases reported in the MedWatch database, the rate of serious hepatotoxicity associated with flutamide treatment was estimated in 1996 as approximately 0.03%, 3 per 10,000. However, other research has suggested that the true incidence of significant hepatotoxicity with flutamide may be much greater, as high as 0.18 to 10%. Flutamide is also associated with liver enzyme elevations in up to 42 to 62% of patients, although marked elevations in liver enzymes above 5 times upper normal limit occur only in 3 to 5%. The risk of hepatotoxicity with flutamide treatment is far higher than with nilutamide or bicalutamide. Lower dosages of the medication appear to have a reduced but still significant risk. Liver function should be monitored regularly with liver function tests during flutamide treatment. In addition, due to the high risk of serious hepatotoxicity, flutamide should not be used in the absence of a serious indication. The mechanism of action of flutamide-induced hepatotoxicity is thought to be due to mitochondrial toxicity. Specifically, flutamide and particularly its major metabolite hydroxyflutamide inhibit enzymes in the mitochondrial electron transport chain in hepatocytes, including respiratory complexes I, NADH ubiquinone oxidoreductase, 2, succinate dehydrogenase, and V, ATP synthase, and thereby reduce cellular respiration via ATP depletion and hence decrease cell survival. Inhibition of taurocolate, a bile acid, efflux has also been implicated in flutamide-induced hepatotoxicity. In contrast to flutamide and hydroxyflutamide, which severely compromise hepatocyte cellular respiration in vitro, bicalutamide does not significantly do so at the same concentrations and is regarded as non-mitotoxic. It is thought that the nitroaromatic group of flutamide and hydroxyflutamide enhance their mitochondrial toxicity. Bicalutamide, in contrast, possesses a cyano group in place of the nitro moiety, greatly reducing the potential for such toxicity. The hepatotoxicity of flutamide appears to depend on hydrolysis of flutamide catalyzed by an arylacetamide decetylase enzyme. This is analogous to the hepatotoxicity that occurs with the withdrawn paracetamol, acetaminophen, related medication phenacidin. In accordance, the combination of paracetamol, acetaminophen, and flutamide appears to result in additive to synergistic hepatotoxicity, indicating a potential drug interaction. Others. Flutamide has also been associated with interstitial pneumonitis, which can progress to pulmonary fibrosis. The incidence of interstitial pneumonitis with flutamide was found to be 0.04%, 4 per 10,000, in a large clinical cohort of 41,700 prostate cancer patients. A variety of case reports have associated flutamide with photosensitivity. Flutamide has been associated with several case reports of methemoglobinemia. Bicalutamide does not share this risk with flutamide. Flutamide has also been associated with reports of sulfhemoglobinemia and neutropenia. Pharmacology. Pharmacodynamics. Antiandrogenic activity. Flutamide acts as a selective, competitive, silent antagonist of the androgen receptor, R. Its active metabolite, hydroxyflutamide, has between 10 to 25-fold higher affinity for the R than does flutamide, and hence is a much more potent R antagonist in comparison. However, at high concentrations, unlike flutamide, hydroxyflutamide is able to weakly activate the R. Flutamide has far lower affinity for the R than do steroidal antiandrogens like spironolactone and cyproterone acetate, and it is a relatively weak antiandrogen in terms of potency by weight, but the large dosages at which flutamide is used appear to compensate for this. In accordance with its selectivity for the R, flutamide possesses no progestogenic, direct, estrogenic, glucocorticoid, or antigonadotropic activity. However, it can have some indirect estrogenic effects via increased levels of estradiol secondary to R blockade, and this involved in the gynecomastia it can produce. Because flutamide does not have any estrogenic, progestogenic, or antigonadotropic activity, the medication does not cause menstrual irregularities in women. This is in contrast to steroidal antiandrogens like spironolactone and cyproterone acetate. Similarly to nilutamide, bicalutamide, and enzalutamide, flutamide crosses the blood-brain barrier and exerts central antiandrogen actions. Flutamide has been found to be equal to slightly more potent than cyproterone acetate and substantially more potent than spironolactone as an antiandrogen in bioassays. This is in spite of the fact that it has on the order of 10-fold lower affinity for the R relative to cyproterone acetate. Hydroxyflutamide shows about 2 to 4-fold lower affinity for the rat and human R than does bicalutamide. In addition, whereas bicalutamide has an elimination half-life of around 6 days, hydroxyflutamide has an elimination half-life of only 8 to 10 hours, a roughly 17-fold difference. In accordance, at dosages of 50 mg per day bicalutamide and 750 mg per day flutamide, a 15-fold difference, circulating levels of flutamide at steady state have been found to be approximately 7.5-fold lower than those of bicalutamide. Moreover, whereas flutamide at this dosage has been found to produce a 75% reduction in prostate-specific antigen levels in men with prostate cancer, a fall of 90% has been demonstrated with this dosage of bicalutamide. In accordance, 50 mg per day bicalutamide has been found to possess equivalent or superior effectiveness to 750 mg per day flutamide in a large clinical trial for prostate cancer. Also, bicalutamide has been shown to be 5-fold more potent than flutamide in rats and 50-fold more potent than flutamide in dogs. Taken together, flutamide appears to be a considerably less potent and efficacious antiandrogen than is bicalutamide. CYP17A1 inhibition. Flutamide and hydroxyflutamide have been found in vitro to inhibit CYP17A1, 17-alpha-hydroxylase, 17,20 lyase, an enzyme which is required for the biosynthesis of androgens. In accordance, flutamide has been found to slightly but significantly lower androgen levels in GnRH analog-treated male prostate cancer patients and women with polycystic ovary syndrome. As such, flutamide is a weak inhibitor of androgen biosynthesis. However, the clinical significance of this action may be limited when flutamide is given without a GnRH analog to non-castrated men, as the medication markedly elevates testosterone levels into the high normal male range via prevention of R activation-mediated negative feedback on the hypothalamic-pituitary-gonadal axis in this context. Other activities. Flutamide has been identified as an agonist of the aryl hydrocarbon receptor. This may be involved in or responsible for the hepatotoxicity of flutamide. Pharmacokinetics. The absorption of flutamide is complete upon oral ingestion. Food has no effect on the bioavailability of flutamide. Steady-state levels of hydroxyflutamide, the active form of flutamide, are achieved after 2 to 4 days administration. Levels of hydroxyflutamide are approximately 50-fold higher than those of flutamide at steady state. The plasma protein binding of flutamide and hydroxyflutamide is high, 94 to 96% and 92 to 94%, respectively. Flutamide is metabolized by CYP1A2 via alpha-hydroxylation in the liver during first-pass metabolism to its main metabolite hydroxyflutamide, which accounts for 23% of an oral dose of flutamide 1 hour post-ingestion, and to at least 5 other, minor metabolites. Flutamide has at least 10 inactive metabolites total, including 4-nitro-3-fluoromethylaniline. Flutamide is excreted in various forms in the urine, the primary form being 2-amino-5-nitro-4-trifluoromethylphenol. Flutamide and hydroxyflutamide have elimination half-lives of 4.7 hours and 6 hours in adults, respectively. However, the half-life of hydroxyflutamide is extended to 8 hours after a single dose and to 9.6 hours at steady state, in elderly individuals. The elimination half-lives of flutamide and hydroxyflutamide are regarded as too short to allow for once-daily dosing, and for this reason, flutamide is instead administered 3 times daily at 8-hour intervals. In contrast, the newer NSAAs nilutamide, bicalutamide, and enzalutamide all have much longer half-lives, and this allows for once-daily administration in their cases. Chemistry. Unlike the hormones with which it competes, flutamide is not a steroid, rather, it is a substituted analyte. Hence, it is described as nonsteroidal in order to distinguish it from older steroidal antiandrogens such as sapropterin acetate and megestrol acetate. Synthesis. History. Flutamide was first synthesized in 1967 by Neri and colleagues at Schering-Plough Corporation. It was originally synthesized as a bacteriostatic agent, but was subsequently, and serendipitously found to possess antiandrogen activity. The code name of flutamide during development was SCH-13521. Clinical research of the medication began in 1971, and it was first marketed in 1983, specifically in Chile under the brand name Drogenil and in West Germany under the brand name Flugeril. Flutamide was not introduced in the United States until 1989. It was specifically approved by the U.S. Food and Drug Administration for the treatment of metastatic prostate cancer in combination with a gonadotropin-releasing hormone, GnRH, analog. The medication was first studied for the treatment of hirsutism in women in 1991. Flutamide was the first NSAA to be introduced, and was followed by nilutamide in 1989 and then bicalutamide in 1995. Society and culture. Generic names. Flutamide is the generic name of the drug and its in, USAN, BAN, DCF, and JAN. Its names in Latin, German, and Spanish are flutamidum, flutamide, and flutamida, respectively. Brand names. Brand names of flutamide include or have included Sabatrol, Cytomid, Drogenil, Etaconil, Ulixin, Flucinum, Flumid, Flutican, Flutamid, Flutamida, Flutamin, Flutin, Flutaplex, Flutacin, Fugeril, Profamid, and Sabatrol, among others. Availability. Flutamide is marketed widely throughout the world, including in the United States, Canada, Europe, Australia, New Zealand, South Africa, Central and South America, East and Southeast Asia, India, and the Middle East. Research. Enlarged prostate. Flutamide has been studied in the treatment of benign prostatic hyperplasia, BPH, enlarged prostate, in men in several clinical studies. It has been found to reduce prostate volume by about 25%, which is comparable to the reduction achieved with the 5-alpha reductase inhibitor finasteride. Unfortunately, it has been associated with side effects in these studies including gynecomastia and breast tenderness in about 50% of patients, gastrointestinal disturbances such as nausea, diarrhea, and flatulence, and hepatotoxicity, although sexual function including libido and erectile potency were maintained. Bulimia nervosa. Flutamide has been studied in the treatment of bulimia nervosa in women. References. Further reading. Sogani P.C., Whitmore W.F. 1988. Flutamide and Other Antiandrogens in the Treatment of Advanced Prostatic Carcinoma. Cancer Treat. Res. 39-131-45. PMID 2908604. Brogdon R.N., Clissold S.P. 1989. Flutamide. A Preliminary Review of its Pharmacodynamic and Pharmacokinetic Properties, and Therapeutic Efficacy in Advanced Prostatic Cancer. Drugs. 38 185-203. doi 10.216500003495198938020-00003. PMID 2670515. Neri R. 1989. Pharmacology and Pharmacokinetics of Flutamide. Urology. 34, 4 Supple, 19-21, discussion 46-56. doi 10.1016-0090-4295-89-90230-6. PMID 2477934. Newling D.W. 1989. The Use of Flutamide as Monotherapy in the Treatment of Advanced Prostate Cancer. Prague. Clin. Bio. Res. 303-117-21. PMID 2674980. Labrie F., Dupont A., Cousin L., Manhays G., Bergeron N., Lacourcière Y., Pinol S., Belanger A., Monfett G., Emmond J. 1989. Combination Therapy with Castration and Flutamide, Today's Treatment of Choice for Prostate Cancer. J. Steroid Biochem, 33, 4b, 817-21. PMID 2689788. Goldspiel Bridge, Kohler Drive, 1990. Flutamide, an antiandrogen for advanced prostate cancer. DICP 24 616-23. doi 10.1177 106,280,809,002,400,612. PMID 2,193,461. Brogdon R.N., Crisp P. 1991. Flutamide. A Review of its Pharmacodynamic and Pharmacokinetic Properties, and Therapeutic Use in Advanced Prostatic Cancer. Drugs Aging, 1 2, 104-15. doi 10.2165000251219910102000003. PMID 1794008. Labrie F. 1993. Mechanism of Action and Pure Antiandrogenic Properties of Flutamide. Cancer. 72, 12 Supple, 3816-27. doi 10.1097-0142199312115-72 12+3.0.co 2-3. PMID 8252497. Iverson P., Melizinic I., Schmidt A. 2001. Nonsteroidal antiandrogens, a therapeutic option for patients with advanced prostate cancer who wish to retain sexual interest and function. BJU Int. 87 1, 47-56. doi 10.1046, J, 1464-410 extension 2001.00988, X. PMID 11121992. Ibanez L., Dezeguer F. 2006. Low-dose flutamide metformin therapy for hyperinsulinemic hyperandrogenism in non-obese adolescents and women. Hum, Reprod. Update. 12.3, 243-52. doi 10.1093, Humapt, DMI 054. PMID 16407452. Brahm J., Brahm M., Segovia R., Latorre R., Zapata R., Paniachik J., Buckle E., Contreras L. 2011. Acute and fulminant hepatitis induced by flutamide, Case Series Report and Review of the Literature. Ann Hepatal, 10 1, 93-8. PMID 21301018. Giorgetta R., D. Musio M., Giorgetta A., Girolami D., Borgia L., Tagliabracci A. 2017. Flutamide-induced hepatotoxicity, Ethical and Scientific Issues. Year Rev. Med. Pharmacal Sci. 21, 1 Supple, 69-77. PMID 28379593.